Okay, good morning, everyone. Thanks for joining us for week 6 of our 12-week ECHO series on health equity and cardiovascular risk. So I'm Jim Werner, and I'm filling in for Gautam Rao as the facilitator today. He's away, but he'll be back next week. Please remember not to use any protected health information during the case presentations and discussions. So here are some reminders. Please make use of the chat feature to ask questions or contribute to the discussion at any time. Also, feel free to unmute and ask questions or to make comments during the Q&A following the didactic presentation that we'll have today and during the case discussion. Contact information is provided here if you have any technology issues or any general comments or questions about the series. So here's some information about Cardio, which is the parent program for our ECHO series. And you can learn more about Cardio if you would like at cardio.org. Listed here are the leaders and content experts for this ECHO series. Today's presenters will be Elizabeth Beverly and from Ohio University and Kelsey Ufholz from Case Western Reserve University. And they will be presenting on the topic of telemedicine and health equity. And Adam Perzinski and Annette Conklin will be today's lead discussants. But as always, we encourage everybody to participate. We'll have one case to discuss today that will be presented by Misty Mail of Hopewell Health Centers. Next slide. Here are the disclosure statements. I don't believe any of this has changed from previous week. Okay, next slide. And with that introduction, Dr. Beverly and Dr. Ufholz, please take it away.
Good morning, everyone. I will introduce myself first, and then I'll pass it to Dr. Ufholz. I am Liz Beverly, and I'm a professor at the Ohio University Heritage College of Osteopathic Medicine. Today, I'll be talking to all of you about telemedicine and health equity, and I'll pass it to my colleague, Dr. Ufholz.
Thank you, Liz. My name's Kelsey Ufholz, and I work at Case Western Reserve University. I work quite closely with Dr. Gautam Rao and Dr. Jim Werner, especially on areas related to health equity and reducing care disparities in primary care patients. So let's get moving. Today's learning objectives is we're going over telemedicine and how that can be used to facilitate health equity and promote such things. We're going to also go over, both for urban and for rural patients, some initiatives to help patients participate more in telemedicine. Now, to start out with, telemedicine really did technically exist prior to the pandemic, but it certainly got kickstarted quite a bit starting in 2020, and it's never really gone away, and I don't believe it will. Patients find it preferable. They can avoid traffic and parking, and for many patients who are at higher risk, such as older patients or patients with diabetes, taking an appointment in the comfort of their own home rather than in a waiting room full of COVID is preferable. Telemedicine is part of a group of interrelated terms like e-health and m-health, which can encompass a lot of different ways in which technology interacts with the healthcare system, such as a patient sending a message to their doctor through MyChart, or a doctor remotely monitoring a patient's blood glucose level. But for the sake of this presentation, I'm going to define telemedicine as a type of appointment where both the patient and the provider can see and hear one another in real time. So pretty similar to what we're doing right now, but a bit more one-on-one. So as I said before, it is quite popular and looks to remain so. As you can also see from this chart, it tends to be a bit more popular among older individuals. which older individuals generally have greater contact with the healthcare system through their greater medical needs, but many of them are no longer able to drive, or even when they can, they find it uncomfortable to drive in heavy traffic or at night, which could partially explain why you see more for these older patients. But at the same time, these older patients are less comfortable and familiar with technology. One reason that telemedicine is so popular is just simply because it works. We're only just now starting to get some really good data and research about the efficacy of telemedicine from projects that compared that to usual care during the pandemic and have had several years to run and then analyze. And even then, it tends to be a bit more of looking at a research-related program that's very structured rather than comparing, say, a virtual primary care appointment to an in-person one. But the preliminary evidence suggests that it can be useful. For example, this slide talks about how telemedicine relates to diabetes care and has shown that it can lead to improvements in some pretty important biometrics such as A1C and body weight as well. And this can be especially true with older patients who, as we've stated previously, tend to use telemedicine more and who are a more vulnerable population. So a little bit of some updated work from a meta-analysis from last year looking specifically at cardiovascular risk factors. It was found that as a general rule, telemedicine tended to have a small to moderate effect on metrics such as A1C, blood pressure, and weight, and not physical activity so much. But the authors wanted to state that even these small results could be clinically meaningful, especially when you consider that telemedicine has the advantages of providing greater access to care and to some extent can be easier for both the healthcare system and for patients. But it's not equally distributed. The slide on the left shows that there are some pretty clear differences in who can access telemedicine based upon ethnic group, with Hispanic individuals and African American individuals, as well as Asian individuals, being less able to access it compared to whites and to Native Americans. Native Americans also being a historically disadvantaged group. My hypothesis is that they are adopting it out of necessity because there are not as many healthcare providers where they happen to live. But even more consistently, you see on the right-hand side, it is an economic issue and an educational issue with individuals who have some college education or greater income being more likely to access telemedicine, which makes sense when you figure that you need a internet-capable device and a data plan in order to access this. So I'm going to briefly go over a pilot study which Dr. Rao and I completed a few years back during the height of the pandemic, the goal being to see what patients' needs were at the clinic that he and I work at, which primarily serves low-income African-American patients. We were surveying 30 patients who were already at the clinic for a chronic care appointment, so diabetes, COPD, etc., something that could be monitored remotely, and who were older. Because we were trying to be respectful of their time, we limited ourselves to 10 questions, which meant that we couldn't get as much as we wanted, but we still got some interesting results. We found that the majority did have an internet capable device and said that they used the internet, but very few had had a telemedicine appointment. And we noticed that nearly half of them had what we would call a budget smartphone, which is relevant because a lot of apps such as Zoom work better on an iOS-based mobile phone. And very few of them had something like a tablet or a laptop, which tends to work better for telemedicine with a bigger screen and a physical keyboard. Most of all patients who had a device said they used it for messaging on the internet, but it's possible that what they defined as messaging on the internet and what we were going for were different. We were thinking about them using an app such as WhatsApp, and they might have meant text messages. So that's something we need to look at. And quite a few of them, that was all they were doing. So if they were sending text messages, then they weren't really using the internet. Very few of them were using it for email or for video calling, which tend to be necessary steps if you're going to have a telemedicine appointment. And none were using it for banking or shopping, which presumably means they were continuing to do these things in person during the pandemic, even though there was an online option, meaning they either did not have the skills or just had not mentally realized that they could do some of these essential life tasks online. But we did find that patients who had a more technologically sophisticated device or who were using the more demanding functions were more likely to have a telemedicine visit, which shows that you sort of baby step patients to that point. To put the same thing into visual context, obviously patients who didn't have an internet capable device were not having a telemedicine appointment or using the internet, but patients who had an iPhone or who were using email were much more likely to have had a telemedicine visit. And I'll let Dr. Beverly talk a little bit about rural areas now.
Thank you, Dr. Ufholz. I'm going to share a few examples about how telemedicine can be beneficial in rural regions. I myself live in a rural region, a rural part of southeastern Ohio, and I can tell you that we experience a lot of barriers that limit access to healthcare in our region, among other regions across the state and across the country. People in rural regions have to travel long distances for healthcare, and there can often be a delay if you need emergency services. So this limited access to care, whether it's through transportation issues or if there's a lack of access in terms of availability of providers and specialists, it can lead to negative health outcomes. That can lead to increased expenditures for patients as well as for the healthcare system. And some of these costs might be travel related. It can be lost work hours. It can be costs related to the caregiving and childcare costs. And so telemedicine provides an opportunity to reduce some of these barriers so that we can bring more equitable care to these rural regions. Next slide. So this is an example about the use of telemedicine, but specifically for a cardiovascular reason, and this is a telestroke service. So the American Heart Association created this telestroke network, which offers low-cost, effective tools to improve access to critical stroke care in rural regions. And so there's an analysis done, this is now a few years ago, but they access claims data from Centers of Medicare. And you can see here that they did this from 2008 to 2015 because Medicaid and Medicare began reimbursing telestroke services in 2007. And so what they were able to show is that the proportion of those who had an ischemic stroke who had these telestroke services, this had a dramatic increase from 0.4 to 3.8 per thousand people. And those who, if you're looking at those who increased with their telestroke services, what they observed were they were younger, they tended to self-report as male, they were non-Hispanic white, and they lived in rural and super rural regions. Next slide. So this is, as Dr. Ufholz did as well, this is just a visual representation of some of the telestroke services and how they increased over time. And you can see here in this graphic, it is showing the uptake. You see a dramatic uptake in terms of rural and super rural for the telestroke network over time. Next slide. Another example of how telemedicine can be used to support the people that you're working with is through diabetes self-management education and support. So about 62% of rural communities have limited access to diabetes self-management education and support. And so there was a pilot trial that was done recently. It was 12 months long with telemedicine. It was done with certified diabetes care and education specialists, and they provided this diabetes education via video conferencing. And you can see here, again, this was a pilot study with 42 individuals, but 64% of them achieved their self-management goals through this pilot intervention, and that was 27 of the 42. Some of their outcomes looking at, you can see that their mean hemoglobin A1C decreased 0.2%. They decreased their regimen-related diabetes distress. In other words, there is a lot of frustration to living with diabetes, and you have to live with it 24 hours a day, 7 days a week. And sometimes some of the self-care behaviors can be very frustrating for individuals. And if you're able to decrease that distress related to taking those self-care behaviors, it can be very beneficial to the patient. And then they were able to show that it improved healthy diet behaviors by participating in this intervention. Next slide. And now I'm going to pass it back to Dr. Ufholz.
Thank you. I'm going to talk a little bit now about a project that I am currently recruiting for with the help of some very good research assistants and Dr. Rao, who is the co-PI. This is a part of a grant from the Agency for Healthcare Research and Quality Improvement. And the goal of this is to increase the telemedicine readiness for our patients, specifically African-American patients between the ages of 50 and 70 who have type 2 diabetes and who would be a good candidate for a telemedicine visit but have not yet had one. And we are basically running a referral service for these patients, and then afterwards we want to find out how well it worked in meeting their needs. So the patients have to be between 50 and 70. They have not already had a successful telemedicine appointment, which I define as an appointment where they were able to see and hear one another clearly, and the patient felt that all of their needs were met. So if they tried to have a telemedicine appointment but couldn't get the connection and had to switch to a phone call or something like that, they're still eligible. The research procedure is after informed consent, these patients are screened for their telemedicine readiness, by which we ask them what sort of device they have, what sort of data plan they have, and how comfortable are they using their device? Do they know how to turn on their camera? Do they already have a headset? That sort of thing. And Cleveland, where we are based, has some individuals called digital navigators who are familiar with all of the digital skills training opportunities in the local area. The navigators are funded by the Cleveland Foundation, and most of them are employed by the Cleveland Public Library. Our research team calls them with the participants still in the room, and we try to connect these patients to the navigators so that they can arrange digital skills training based upon the patient's preferences and needs, with the goal being that they will then have a follow-up diabetes management appointments scheduled for 6 months later. Our primary outcome is just, did they have a telemedicine appointment at that time? Yes or no? And because it's new and this is a pilot that we're hoping to turn into an R01 later, we're going to do some semi-structured interviews, both with patients who did have a telemedicine appointment ultimately, and those who did not. We want to find out how the telemedicine experience was, how the training experience was, and in the case of those who did not have a telemedicine appointment, what the sticking points were that we need to work through. Currently, we're a little bit less than half in recruitment, and I asked my research team members what sort of feedback they were getting from the patients. A lot of the patients said that they were coming into the clinic just to have an appointment so they could get their prescriptions refilled, and being able to do that remotely rather than having to come in person was quite a perk for them. And usually the first question people ask about telemedicine is my insurance gonna cover that? So having it be covered by insurance was also a bonus for them. So we've gotten quite a bit of positive responses, and I'm hopeful that we'll see quite a few of them on Zoom rather than in the clinic in about 6 months. That takes care of my portion.
Great. Thank you, Dr. Beverly and Dr. Ufholz, for that terrific presentation. Let's open it up for questions. So if you have a question, please unmute and ask your question, or you can type it into the chat.
Thank you for this really interesting presentation. I wonder if, I know it's early still in the qualitative study, but I wonder or if in other studies, you've heard anything about the patient's use of the Affordable Connectivity Program. And also, if you've heard anything recently about fears about the Affordable Connectivity Program possibly expiring, and so patients who receive that very low cost internet for $10 or $15 a month now are at risk of losing that subsidy in the next couple of months.
That hasn't been specifically mentioned. One of the other qualifiers for this study is that they have to already have an internet connectable device and some way of using it. Because in a 6-month study, that's really not enough time to set someone brand new up with a device and internet. But yeah, that's definitely something that we're going to have to watch as the study progresses.
I do have one question for Dr. Beverly. The DSMES, the Diabetes Self-Management Education and Support that was delivered by telemedicine, was that group or individual or a combination of those two?
I believe that was group
Okay.
education.
Okay, good. That can be challenging. Dr. Ufholz has done a project like that, and I have one too. So interesting, and it's great to see those good outcomes that you got. Okay, or that they reported. Any other comments or questions before we move on?
Not a question, one quick comment, if I may, Dr. Ufholz. Fantastic presentation, thank you. The one slide that showed the greater uptake on the part of the elderly participants, and then your comment that they were still not fearful, but not that familiar with technology. The thought in my mind was, there's a greater uptake with telemedicine for an elderly person because he or she realizes it's a convenience, and that's going to carry over to the realization that technology is our friend. It's just a matter of convenience. So I suspect strongly that that will help older people be more comfortable with all forms of technology.
Okay, so we'll wrap it up. The topic of next week's presentation will be cardiovascular risk in menopause. I hope you can join us for that and more case presentations and discussions. And Andy, I'll turn it over to you to wrap it up.
Thank you. So thank you to those who attended our webinar last Wednesday. Our May webinar is now open for registration. So feel free to register through our website or through the QR code. Next slide. As always, all past and present echo clinics are available on our website. And then a post-clinic survey was sent to you. Please finish that by tomorrow at 5 p.m. I sent out the case study schedule again this week. Please let me know if your date doesn't work sooner rather than later. And if you have any extra cases or still need to submit some, please feel free. We will always take more cases.
All right, everybody have a good day. See you next week. Bye-bye.